healthcare business podcast from the Coker Group that focuses on solutions to help healthcare organizations effectively navigate the changing healthcare industry landscape. All right, well, welcome back to another episode of Coffee with Coker. And today we have a guest who's been on the podcast a couple times before. Jeannie Cagle is joining us, and Jeannie is our resident expert, go-to person on all things coding. She has many years experience, both from a clinical perspective as well as just from a coding expert perspective. And what we wanted to talk about is very timely to what's kind of developing in the coding realm today. As we record this in early August of 2020, there are some changes coming down the pipe, and the CMS was planning to release the kind of initial proposal for what those changes to E&M codes were going to look like in July, and they didn't actually come out till just the 3rd. So that was just, as we're recording this a few days ago. And so what we want to do is just bring Jeannie in to briefly talk, give us a kind of a rundown of what the initial proposal and clarifications from CMS look like as it stands today here, just after their August 3rd announcement. But really, we're looking ahead for these changes to go into effect January of 21. There are some opportunities and a number of things that our clients need to be thinking about and working on as they are preparing for and thinking about making adjustments for what's coming in really just, it's hard to believe, a few months from now. So Jeannie, welcome back to the podcast.
Thanks, Mark.
Yeah, and why don't you give us a quick overview, just the proposed changes from CMS and their most recent announcement, and what that looks like as far as the changes coming down for E&M coding in January.
Okay, so yes, you're correct. The proposed rule came out this week, much anticipated. I will say that COVID and telehealth took center stage, and so there's a lot of information that was much needed as far as those categories are concerned. But the E&M changes are going to proceed. Not a lot was changed as far as this proposed rule. Of course, we'll need to look at the final rule that should come out in November. But for now, we're going to proceed as though these things are happening, because it appears as though they are. Just as a summary, E&M are professional services provided by physicians, and the only set of codes that are affected are office and outpatient visits. So it doesn't affect hospital, nursing home, emergency room, those environments. It's only for office and outpatient. But there has been an initiative between the AMA and Medicare, CMS, to put patients over paperwork. And you can imagine doctors are really excited about that. So what they've done is simplified what needs to be documented to support the billing of a professional service that's rendered by a physician. So just to kind of give you the highlights of that, for the past 25 years, believe it or not, the history, the exam, and the medical decision-making are the three key components that determine the level of an E&M code. And of course, the higher the level, the more that's billed and paid for that service. Starting in January, history and exam will no longer be counted toward the level of the code. The guidelines say that they will be looking for a medically appropriate history and exam, which I can tell you from an educator standpoint, it's a huge relief. I don't have to fuss at doctors who don't put a family history on a 96-year-old woman, because it doesn't matter. They can document what they believe to be medically appropriate. That's really important. Another thing that's happened is they are clarifying the ranges of time. So in the past, there's been a typical time assigned to each E&M level in the office. Now, starting in January, there will be a time range. Let me give you an example. A 99214, which is an established patient, fairly sick patient visit. At this time, the typical time is 25 minutes. Starting in January, the range is 30 to 39 minutes. So they're being very specific with these minutes count for this code. Another thing is you can use time to support a code. And it can be time outside of face-to-face time with the physician. In the past, the only time that counted was when the physician interacted with the patient face-to-face. And over half of that time, they had to be counseling them about something medically. Now it's time spent in that date of service, but it can be for that physician reviewing records before the patient came, or that physician making a phone call to a specialist afterwards to give some information. So that's huge. Now, it has to be with the physician, not the staff, but that's finally giving physicians some payment for time that they're spending. There are certain specialties, for instance, oncology, that spend an inordinate amount of time reviewing notes and talking to specialists and that sort of thing. So this is good news for those practices where they spend that kind of time. One other thing that's come out with these new guidelines is there has always been vague phrases used in the past that all of us as coders, if we were to get in the room, we'd all fuss and carry on about what they mean. The AMA has specifically clarified a lot of gray areas, which is huge. They've been very specific about what these phrases mean, whereas in the past, we were actually guessing. So the ability to look at a note and be able to assign a code has actually gotten a little bit easier, not only for physicians, but also for coders or auditors. One aside, they've also added some prolonged services codes that are only 15 minutes in length. In the past, it had to be at least 30 minutes. So you were having to spend a lot of time to bill for additional time. So all of these things are good news.
Well, that's what I was just kind of going to say, because from your summary, it sounds like for once we're going in the direction of kind of trusting the clinician, the physician a little bit more, and
Yes.
and giving them a little bit more free rein to do what they know is right and necessary. And oh, by the way, we can get reimbursement for that, rightfully
Yes.
so, and not put the burden, as you said earlier, on documentation, or not put the focus and emphasis on documentation. Instead, we want it to be where it should be, which is on the patient and the type of care. And I think the example of oncology is a great one, where there's so much more than just that face-to-face encounter.
Mm-hmm.
So when you think about all of these things at kind of a ground level type implementation perspective, what do you think the impact is going to be for a physician or a practice-wide group, or a hospital-owned, health system aligned medical group, as far as the documentation and the operational kind of standards and procedures for running that practice? How do you think some of these changes will impact them?
That's a great question. So what I've been hearing, word on the street, if you will, is that a lot of physician groups and physicians are thinking, you know what, history and exam don't matter anymore. So we're not going to have audits, and we don't need to worry about it anymore. When actually, in my opinion, it's shifting in a different direction. All of that is definitely a benefit for the physicians. You're not asking them to do ridiculous things. And they've already had all kinds of things like quality measures and MIPS and MACRA and all these things dumped on them. So they needed to come up for air and get something positive. But think about some of the things from what I just told you briefly that are going to have to be decisions made internally, and the physicians are going to have to be educated. First of all, think about there are EMR systems that are set up with what are called code calculators. And so the physicians were not assigning codes based on their knowledge. They were counting on the computer to say, you have enough of this and this, the code is now this. You have to disable, because the history and exam don't carry it anymore. So the physician is going to have to assume a better understanding if that's how they've been assigning codes, which means you need to involve your EMR vendor, and you need to ask them, how do we turn this thing off? Another thing I would say is super important is to determine, if you're going to use time, go back to the oncologist, where is that time going to be documented? Is it a free text? Because you have to document the time, but you also have to document how the time was spent. So you wouldn't just say, I spent an hour and a half on this patient and just bill a code. You would say, I reviewed records, contacted Dr. Stone. Well, where does that go in that EMR template? At this point in time, they're not structured that way. Are you going to want them to free text it? Are you going to create a macro? How is the doc not only going to do that, but going to track that time? Because that would be a new thing they've not done in the past. Another thing is, remember that physicians, specialists in particular, often see hospital and office patients. So they're going to be confused. The rules still apply in the hospital. They don't apply in the office. So helping them navigate how to handle both of those. We don't want to create burden. We want to do everything we can to help them have all the tools in place to better understand it. So just to say, good news, we don't have to worry about it anymore, probably will lead to more confusion than help. I will say there was a touch of bad news in the proposed rule where the conversion factor has been decreased quite a bit, actually, but the RVUs for these particular office visit codes actually were increased. So there should be a positive revenue result for docs. All of those things also need to be kind of considered because they might make a difference when it comes to compensation models and those sorts of things. Once again, the bottom line is every claim submitted has to have supporting documentation. So the physician understanding what that looks like would be really, really important. The other thing I would recommend is that they look at the process of documenting. If you're going to work on your template, look at the new verbiage used by the AMA table of risk, which goes to medical decision making, and use that verbiage in your template. For example, controlled and uncontrolled, meeting goals of care, stable versus unstable, all of those, if a physician learns to use that verbiage when they document, then they can be sure it would pass muster in an audit. So, if you're going to explain it, put it in a way that helps an auditor and frankly helps in continuity of care if another physician is reading your note for a variety of reasons so that you can better kind of express yourself. I think you kind of have to drill down and think about all of these things change. Your process changes for your staff. There are a lot of places where it changed. Don't ignore those things.
Yeah, that's what I was going to say. I mean, it sounds like definitely some learning curves potential here, and even some, just a basic period of transition and what that new model is going to ultimately entail. Because I could see there being some initial confusion, like you said, going back to the hospital versus the practice patients and some kind of different models there. But like with anything, once you get the process updated, your people trained, the education in place, and then have some time to get used to it, I think net, we're looking at overall positive changes. I want to get to kind of what do they need to be thinking about now as far as preparation and training for those changes. But before we do that, you referenced earlier that a lot of the changes, there was an emphasis on telehealth and COVID-19. Or just any comments that you want to make as far as how telehealth intertwines into coding and specifically E&M coding going forward?
Yes. So just in general, because there was a lot there, telehealth was one of those things Medicare was kind of limping along, and then the pandemic hit and it just escalated. And I think even providers, I think everyone is realizing there's definitely been a benefit here that has been a bit surprising. I don't think it's the norm everybody wants, but there are certainly possibilities. What they've done is they've clarified some of the gray zones. They have extended some of the deadlines. They have talked a lot about immunizations for COVID and all in anticipation of those coming out at some point, and how they will be for Medicare patients, how they receive it, how you bill, those sorts of things. So everyone can curl up by the fire and pull up the proposed fee schedule and take the physician fee schedule and take a look at it. But there's really a lot of great information in there. Telehealth morphed, started in March and then changed and then changed and then changed and then changed. So I think it's really kind of an attempt to kind of hem it up, for lack of a better term, just kind of pull it all together. And back to your point earlier, not only are we asking physicians to get the hang of telehealth quickly, these other rules that are changing in January, they've been in place for 25 years. I'm personally, as an auditor, have been doing this for 20 years, and I kind of dread the change. I don't like to rearrange my furniture in my house. I like to just kind of leave things the way they are. So, change is hard. I would just say to every administrator, every billing and coding person, be patient. Be patient. Everyone, anytime you have this kind of a paradigm shift, it just takes time.
It does.
So be nice.
That's a great point, and it's a great segue because as administrators and billing and coding folks are listening to this and thinking about, all right, we have more change coming. We got to deal with yet more change. I think, again, as we said, this is one of those instances where it can be very positive, but change is change, and so there's still sometimes challenges and even hurdles that you have to overcome even to deal with positive change. So
right.
We have a little time though. Again, we're in August right now, which is crazy to think about. So we have at least a few months to start thinking ahead. What are some of the things that you're telling clients and that you're working with folks out there on thinking ahead? What are some of the steps they can be taking today in August, preparing for January 21, and then kind of going forward from there? What are some of the things you're recommending?
I think we all function well in denial. It's great to say, oh, it's only August. But the reality is, especially if you have a physician group that's fairly large, you've got to have a plan. One thing that has been really refreshing in this, just go to the AMA website. Believe it or not, they have got some wonderful tools about telehealth, about this E&M. They actually have 10 tips to prepare for the E&M changes in January. And it talks about how to implement what you need to do next. I've been very impressed with the tools. They're easy to use. The AMA is really trying to give out a lot of information. You've got to have senior management buy-in to make it really clear that you've got to provide physician education. Your best resource is an educated physician, somebody who understands, here's where the changes are. Here's how I think it would look best in the note. Let them drive from a clinical perspective what you need to back up from the coding perspective. I think we've always gotten that backwards. We go in with our coding rules and have the doc comply. I say, ask that physician, tell me how you treat a patient, and then let me tell you how to make this document reflect that in a way that will pass an audit. And clinically, you make sense. One more reminder, we're going to have a final rule come out in November, but I think we can pretty safely proceed ahead. Impact areas, keep in mind, if you've got to make template changes, you may have to get your EMR vendor. They're going to be swamped with people from every direction. Can you update EMR templates internally? Then get that person on board. Do you have to talk with the vendor themselves? All of that, you need to go ahead and do that ahead of time. If you have in-house coding auditors, people who do in-house audits and education and that sort of thing, they need to be educated. You need to give them everything they need to get up to speed. They're going to need to change how they audit these outpatient notes. You can't assume that they're going to just read a few articles and get the hang of it. So be sure you're giving them all the resources that they need. And your office might need to change the process. We have a lot more people putting in information over a web portal, taking that information, preparing it for the physician. Right now, it's heavily weighted toward the history and exam. Go back and ask the doc, what part of this do you want? And what part of this is what they call note bloat, where you've got all kinds of fluffy stuff in there and it doesn't have a thing to do with why the patient came, and get the physician's feedback on that sort of thing. And you may need outside help. Not everybody does. Some people have a wonderful resources internally. I will say, sometimes I find that internal coding teams do a great job with behind the scene auditing, feedback to the physicians, but to communicate new information or often hard information, sometimes you need somebody from the outside because it can be a little more concise. You can have the conversation with somebody from the outside and it can augment what those coding auditors internally are doing, I have found 99% of the time they're delighted to have the help. So sometimes you might need a liaison. One thing we're offering to our current clients, and certainly good for others, is what we're calling a parallel audit. So in the fourth quarter of this year, for the clients who are up for audits, we're doing our audit as we would with the 2020 rules, but we're putting in a column and auditing those same notes using 2021 rules just for that one quarter, so that we can communicate with the physicians, you know what you're doing, it still works. Or, you know what, now you need to add this or that, or this doesn't matter, or to just kind of give them, sometimes that's helpful to a provider to kind of have it right in front of them and see what the differences are.
Yeah, I think that parallel audit is interesting because I think that could be a really simple tool to get at least a little bit ahead of that curve, because that is probably a quick way to identify where there may be some gaps and fill in gaps rather than trying to reinvent the wheel and start from scratch on the entire coding process. In some cases, I think you're right. I think this is one of those changes, like many, that could go a little bit deeper than maybe we realize. So you talked about some of the process-oriented stuff that goes on in a practice or a group, particularly a large group, where some of the standards and methodologies for doing some of these things can vary even amongst different locations, different physicians, different teams, pods, et cetera. So I think that's something that would be healthy to look at. And then again, like you said, just the training and education, just whether it's internal or external resources. I mean, I know that's one of the things we're putting together is training, and that can be general or kind of generic high level information and education. It can be tailored training towards a specific, what a specific group needs.
Yes.
And then tying that into what are some of the procedural stuff that needs to change, or the technological stuff that needs to change related, like you said, to EMR templates and other, technology that may be involved in this process. So
yes.
The good thing is none of those are overly complex, I guess. Those are all some things that can be done fairly simply and quickly and cost efficiently, and probably make a lot of headway and progress towards making this transition, I guess, easier to bite off, probably.
Yes. One other thing I'd like to add is, once January comes, give it a good 60, 90 days and then go take a look, because you may find some gaps that you didn't anticipate as the physicians, attempt to make the transition. I anticipate there are some docs who don't like change so much that they'll just keep doing what they're doing. And certainly it's not wrong to still do this very robust history and exam. But should you choose to be a little more streamlined and only include the things that clinically make sense to you as a provider, that's now allowed.
Yeah. Yeah. And I think telehealth is another great example of that. I mean, not everybody is going to jump deep into telehealth, particularly after the pandemic limitations fade away. But as we've said in the past, covering telehealth, it's definitely here to stay, and it's going to be greater than what it was in January and February of 2020. So I think that's something that, generally speaking, the majority of providers out there, systems, groups, et cetera, are embracing one way or the other, some more than others perhaps. But that's going to be something that is going to, I think, require continued check and evaluation, whether every quarter or every, couple times a year, whatever that looks like. There's going to be an ongoing evolution there as far as what that looks like and how that works.
Yes. And I will say, some people are like, hey, this is great, we don't need to audit anymore. Well, people don't do what you expect. They do what you inspect. And so just to follow up, that's just prudent. We all, need that in our lives, is just checking in here and there by somebody from the outside to say, hey, here's what I see. And it's still a compliance risk. What's being billed has to be supported. So audits still need to take place.
That's right. Good point. Well, I think that's very helpful information, and probably a good point of conclusion here as far as where we're at now. As you said, the final rules anticipated November, I guess maybe certainly by the end of the year, obviously, but maybe November, December,
yes.
would be likely. And we've already Coker's already put out some initial information on this. We'll be continuing to talk about this and covering the new developments and how the kind of evolution of these changes going all the way into January of 21 and beyond, obviously. And so there's still more to come on this. And so everyone can stay tuned to Jeannie and any of the content we put out as to any new developments and ongoing information. So other than that, though, I appreciate at least giving us a rundown of where we're at now and what we can look forward to.
Okay. You're welcome.
Thanks, Jeannie.
We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We would love to hear them and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter at Coker Group, and then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback. And we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.